So without further ado, then we'll get started with a brief presentation. This is a bit the structure of tonight. So we'll have a few slides, we'll have a few videos, plenty of discussion in between, and a bit of discussion at the end. So Roland, over to you.
Thank you very much, David. I would like to just start by making the point that most of the colonoscopy we do is about cancer, about finding cancer or excluding it and definitely preventing it. Next slide. Now, we see in lots of studies, whatever we look at, whatever performance indicator we look at, we see variation in activity, in performance, I mean. And here we have the post-colonoscopy colorectal cancer 3-year benchmark rates for English hospitals in 2011 to 2013. And we see a big difference across the 140 odd hospitals are there. And we also see that this problem is occurring in Denmark, and there's evidence from Sweden and Belgium that post-colonoscopy colorectal cancer is a problem, and there's variation. And the only reason we don't have that information for other countries is they haven't looked at it yet. But interestingly, in our bowel cancer screening program, the rate was only 3.5% or so. In my own unit, it's about 5.1%. Next slide, please. So really, if we can't get the top 3 things right, why do we bother to do our job? This is our everyday task. It's what most of us do in the endoscopy suite most of the time. And really, why are we doing it if we can't do it as well as it can be done? Next slide, please. So the learning objectives for tonight are understanding why colonoscopy withdrawal technique is so important, knowing what circumstances lesions are most likely to be missed, understand what colonoscopy techniques improve visualization, understand how to use tip attachments, appreciate the potential of AI to improve visualization. And we're really just on the beginning of the journey with AI. And very importantly, I want you to be thinking all the way through of things that you might do tomorrow to make a difference on the back of what we're covering tonight. Next slide. So we then go back to Poland. Next slide. And these authors confirmed this association between risk and adenoma detection. So better adenoma detection in the right-hand scale. Next slide. And then we hop back to California. And basically this study, which was reported last year in JAMA, extended the study of Corley from 2014. And it was a much bigger study. And it was for Kaiser Permanente in both the north and south of California. And there's a couple of things about this. It showed this difference between adenoma detection rates and subsequent risk. We see the cumulative incidence on the y-axis. And the thing I want to point out is that this isn't just a cancer occurring in the first year or two after colonoscopy, as we often see in the benchmark studies, but actually, if anything, the rates of cancer appearing are increasing over the years. And these are likely to be mostly missed lesions, precursor lesions. And we've seen this in our own studies. We've looked 6 to 10 years out of colonoscopy, and we see a continuing rise in the appearance of cancer. And this is very likely due to, in most cases, inadequate colonoscopy. Next slide, please. So this group worked out that for every 10,000 colonoscopies done, and we're looking over a 7-year period after the colonoscopies, you would see 12 additional cancers in the group below the median. So the median ADR in their study was 28.3%. And if you looked at all the colonoscopists below the median, then you would see in that group, for every 10,000 colonoscopies, they do 12 extra cancers, i.e. cancers not prevented. Next slide, please. So how can you perfect your technique? Well, if that's the most important comment, this is probably the most important slide, really, because it really summarizes everything that we do. And all the hyperlinked items on these lists, we're going to cover in the presentation in one form or another, but we're also going to be showing you some slides, a video of 2 withdrawals that John did last week. They haven't been chosen for perfection. They're just the 2 consecutive patients, but just to show you some of the things that we're talking about here. And very briefly, obviously, PrEP is critical. Mike Burke in GIEQs last year, the symposium, really emphasized the importance of use of simethicone. He very low tolerance of bubbles in the colon. We need to get our technique right, and we'll be covering all these things. And I'm really passionate about that 3rd column. We get distracted, we get tired. We're dealing with multiple pathology. Our attention is really being strained. Some of us are working all day, doing 10 or 15 colonoscopies in a day. And we sometimes have patients who've got a really high-risk colon, and they need extra special attention. And then, of course, we have the fancy technology coming forward. But I'd put it to you that if we don't get these things to the left of that final column right, the use of the technology, particularly artificial intelligence, if you're not visualizing the whole colon, the AI is not going to do the job for you. So basic techniques using with a clean colon and being aware of your own self when you're scoping and being tired and distracted is really important. Next slide, please. Okay, so I think this is really important there, because the point I want to make here is that for any new technique like this, I think you've got to give it a really good go. And you've got to master the technique before you dismiss it. And I was guilty of using the cuff maybe a year and a half ago, and I just found it a bit awkward and didn't really help very much. And then I stopped using it, and then I went back again. I thought, well, I need to just look at this again. And I spent more time just refining my technique of holding the folds back, particularly using it in the left colon, which we haven't shown here. And now when I don't have a cuff or a cap on the end of the scope, I feel like there's a bit of me missing. It's like you've gone out, you've gone for a walk and you've forgot your right sock or something. Just something doesn't feel right. So the key message here I want to say to everybody, if you embark on using a new technique, whether it's the cuff or the cap or dye spray or anything, before you give up on it, please master it to the point where you are completely competent. And if you think at that point it's still not adding anything to your practice, it's reasonable to stop using it at that point. But don't give up until you've given it a good go. And that goes for turning the patient and lots of other things we're talking about today.
Now, people say the cuff reduces your field of view. It probably does, but the benefit of it is it gives you great stability for therapy. It's also very handy for moving the folds out of the way. And actually, when you're doing underwater intubation, it's a real aid because it keeps you 3 millimeters away from the mucosa. So when you're underwater, you can see the normal grooves and you can decide on the direction of travel. So I like a cuff for many reasons. It's a different type of distal tip attachment, but it certainly helps with your withdrawal technique and your adenoma detection technique.
You may not have seen. So Roland shows you that nice graph which goes out to a long period of time during which the incidence of post-colonoscopy colorectal cancer keeps on going up, and presumably some of that is small polyps that we miss in the initial stages. And so let's just see some examples here. So we have one here. You're pulling back using a cap. You think, yeah, well, I'm pretty good at detecting adenomas. And then suddenly you get a detection like that. Now, you saw it just in the distance, but did you see it? Because I definitely didn't see it. So if we just come back and play that again, one of the great things about AI is that it is able to pull out things from the background, which potentially you wouldn't have seen as you flick past them. There's just that little box there, right? And then when you go in, there is a polyp there. Now, I mean, I don't know, let's start with Vikash. Do you think that that's something that in your practice you, one, would have seen, and two, do you see that as the incremental value of artificial intelligence, or do you see it differently?